Okay, let's get it rolling. So coxofemoral bypass in this trauma, I think where everybody wants to nail and plate, I thought let's give a different perspective to our way of looking at these patients. So coxofemoral joint, as we all know, is nothing but articulation of the acetabulum with the femoral head. And there are 3 degrees of freedom of motion there. All sagittal plane, we know flexion, extension, coronal, adduction, abduction, and in transverse, we have internal and external rotations. So as we know, internal IT fractures have been always a challenge. And I see a lot of talk going on how try to get a perfect reduction, put a Hohmann, reduce the fracture, see that unstable is trying to become a stable fracture. So just to give the stats, the incidence of all hip fractures is about 80 per 1 lakh patients, and of which intertrochanteric fractures take about 45% of all these fractures. Our aim has been to mobilize early, because all these are geriatric patients, and return to their prospective activity as early as possible. The surgical treatment for intertrochanteric fractures is a challenge, as I said, because of the modalities of treatment that is available to us. It's equally encouraging as well as confusing for most of the young surgeons. So intertrochanteric fractures, I don't want to go into the details, the definition wise and all, we all are familiar with it. What is important in this is the calcar. So calcar is the part which decides whether your fracture is going to be a stable in anatomy or it's an unstable fracture. And that is what as a surgeon you need to figure out. Classifications, I think everybody is aware of it. And what as a surgeon we would like to know is whether your fracture pattern is stable or unstable to plan your fixation of these fractures. So stable fractures, we know that intact posterior medial cortex is there, and an unstable fracture, well, we see the LT flying and you know that it is a unstable fracture and we need to use a lot of thought process in getting these fractures fixed. So these are the common fractures that we may come across. Treatment options, non-operative, we all know the consequences of non-operative management of IT fractures, the high mortality that follows them, and higher incidence of pulmonology complications, decubitus ulcers, and DVT. So operative is the one which we need to convince the family and also the challenges behind these geriatric patients. So we have closed nailing, open nailing, and we have arthroplasty at our disposal. So challenges of nail fixation has been to get an anatomic reduction. So that has been always a challenge. To get an anatomical reduction, there are various methods which we all are aware of before we take even the incision. Then another challenge that comes into our hand is the quality of the bone, the osteoporosis. We can't afford a revision. The previous case, what Dr. Babulkar had shown, you know, 80-year-old, 78-year-old lady going through multiple procedures, and for her to withstand all the procedures is always a challenge for us. So we would like to give one shot at the patient and try to get the best outcome for her in the leftover years of her life. So proximal screw, we know what are the problems which that the screw has, the PFNA has, where we know that the forces, the torque limit, the forces are not properly transferred from the femoral head down to the shaft of the femur. Intraoperative failures to achieve reduction, and we all are familiar with the Z and the reverse Z phenomena that happens when we have these fractures going through their healing process. Loosening of the pins and also anterior thigh pain has also been documented about these. So these are some of the fractures and the complications that we have with IT fractures. Following the standard nails, there are various nails in the market. We all are quite versed with it. Every implant company comes with an edge of a technology behind the nailing concept, but still we are struggling to get them right. So just to highlight the Z effect, where the and the reverse Z effect, where the lateral buttress deficiency is always there, an unstable medial cortex. There is a constrained friction between the femoral head and the axial loading in varus. So osteoporotic head, so we have the proximal screw migrate medially and the distal screw migrate laterally, whereas the reverse Z, the proximal screw backs laterally and the medial screw backs medially. So this is the fracture which we come across, intertrochanteric fracture, and as we see, it's an unstable fracture. One of my colleagues had fixed it, and this was the fixation. Sorry, I don't have the lateral, and we know that this is not a good reduction, and what the consequences are going to be. Within a month or two, these patients, even on partial weight bearing, has backed out, and then we think of revising this case, and what we do is the lateral position. We take a hard hinge approach, and we split the incision with a gluteus medius proximally and the vastus lateralis distally. The GT is split with the anterior and the posterior fragments. What you see in front of you is the neck, and we can use a owl to enter the neck. The neck can be identified very easily because there's always a little bit of calcar left with it. We enter the neck through with the owl, with the corkscrew, which most of our sets have, and dislocate the head. So this is just to show that this is the neck, what you see in this picture, and then you have the anterior break of the neck here. You can see the corkscrew is inserted through the calcar, which is here on the neck region, into the head, and we are managed to dislocate the head. So later is the challenge of fixation, and as we know, there are ways of fixing the GT after we have done through this approach. So wires are usually fixed into the proximal femur with about 2 centimeters distal to the fracture. And after we do the prosthesis trial and reduction, we need to restore the GT in these cases. So this is the post-operative X-ray of the same patient. I would have liked the stem to be a little longer, and this is how the final outcome of this patient is what we have. So advantages of hemiarthroplasty: early mobilization and weight bearing. We can start the patient day second. Reduction is reduction in immobility related complications are there, where we don't have any other complications of immobility. Suitable for patients of osteoporosis, early weight bearing, and bedridden syndromes can be avoided in all these patients. Arthroplasty, there is enough literature to say that they are the for the most suitable recommendations for patients in the geriatric age group with complicated IT fracture. And selection criteria: all elderly patients, advanced age, severe osteoporosis, combination of GT, and unstable intertrochanteric fractures. There are various techniques described to fixation of the GT. This is one of the procedures where we have SS wire passed in the shaft of the femur, get the GT together, and then we pass the wire around it. The GT can be fixed in various ways. In this case, it is just tied with the figure of 8 SS wire. The other methods of fixation of GT is based on the combination the GT shows. You can fix them either through cannulated cancellous screws. We can use wires to fix the GT. I don't want to waste time in that. And there are even square plates to fix the GT, where we know that the screw gets buried as you tighten the screws in the GT. So the square plate is helpful in such situation. Other technique of fixation of GT is when we pass the wires. First we assemble the GT together. You can see in this picture that we have passed a K wire and this is the GT. Then cannulated cancellous screws are put to hold the two GT fragments together with a washer, and then the SS wire standard procedure has been done. So success of hemiarthroplasty cemented or a long stems uncemented is the best way to go forward, where you maintain the abduction tension, restore the limb length, and you have a greater trochanteric reconstruction of these patients. To summarize, treatment of unstable intertrochanteric fractures in patients above the age of 65, it is very difficult to get anatomical reduction and fixation. Hence, I think hemiarthroplasty should be considered as an option to go ahead with that. There is various literature, current and past, from our country to show that this is a very established procedure to consider rather than struggling to fix these IT fractures. Thank you.